There's a lot of richness here, and very clearly not just an academic treatment of how do we prevent suicide, but real stories, real tips, real techniques. I want to build on that. I welcome comments, welcome questions, but Dr. Wood, you mentioned something that was interesting and also concerning, which is you mentioned, well, there's all this literature and all this research, but when working with my patients, with my clients, some of it's applicable, some of it's not. And I know I've seen that, and I'm not a mental health expert. I've certainly seen it in the patient population that we work with in Northeast Baltimore City, South side of Baltimore City. What are your perspectives on, is there enough research with the patient populations that each of you four serve? Is there more of a need of focusing research and development of best practices for those specific patient populations? Or is the research enough and it's just a matter of adapting that research to the unique circumstances of each individual client? Any thoughts?
Well, I think my excitement about this conference was, in some ways, I'm hoping it would prompt some of that to happen. Oftentimes, we research people who are convenient to be researched. And frequently, much of what we know, one thing about suicide, we have much of the attention has been on, in general, people who are suicidal. So when you see this population that, as they get gray hair and male and, that they're more likely to kill themselves, well, they're probably measuring for a population that I know that doesn't even live to that point. No wonder they don't show up, That population is probably more likely to be suicidal at a younger age. Frequently we've made all these, we have all these levels which people have made to protect themselves based on a population that has not been ones who have had serious mental disorders, or oftentimes who have been excluded. Most of our studies, to be good, have actually excluded the very people that I'm working with. So excluding multiple diagnoses, excluding people who don't have education, or excluding people who don't have resources, or excluding people who are homeless, or people who have this population really is a significant proportion of the people who actually kill themselves, but is actually not represented in the literature hardly at all. And therefore, many times the approaches we use, for example, how do people kill themselves? Well, most of the time we think, the most dangerous ones are people who, men will shoot themselves, right? People with schizophrenia, it's not their primary way of killing themselves. Many of the people with serious mental disorders, that isn't even not what their approach. And so, yes, I think, do we need to research this? Do we need to probably talk about it more? Do we need to also look at, in terms of prevention, do we also need to research ways of working with such individuals? So that our emphasis has been really on treatment, and in some ways, I think we need much more research on infusing, as you mentioned, prevention in the treatment process, which is something that I think we're all kind of guilty of not doing as much of that. But yeah, I think there's many opportunities there.
Thank you. Nikole?
Yeah, I wanted to just add, I agree with you, and I wanted to add that there are a couple of levels. I think we need more specific research. I think the research needs to talk the same language so we can compare across different groups. But in our veteran population, we have, our younger veterans are having suicide attempts and death at a rate that is not normal for their age group. But we still have our baby boomers where the number of suicides are high. So there are different levels of research that needs to occur, because I think in each group, there are different reasons that are leading them to think about suicide. The other thing is, when I do the education, I say there is no suicidal box. Because I think when we say, here's the box, and the people who are suicidal are inside, we miss a lot of the outliers. And honestly, I think that what happens inside someone, it's hard to predict that. Because for one person, they may have a list of risk factors and it be too much. And someone else may have a list of protective factors and it not be enough. So I just really look at that box and say, you have to know the risk factors and the warning signs, but don't try to put someone in a box, because unfortunately you may miss something on the outside that's actually drawing them to suicide as well.
And look at the protective factors as well.
Yeah, of course.
That's very helpful. To build on that, so maybe I'll ask TJ and Frida this question. TJ, you work in a community-based organization that's not academically affiliated, right? I know, Frida, that's the case as well. My suspicion from the experience at Concerted Care Group is we are very focused on the provision of services and are staffed accordingly, but not staffed to do research. We don't have research assistants. We don't have methodologists. We don't have trialists. We have loose affiliations with academic centers, but there isn't that infrastructure in place. TJ, has your organization been involved in research, and have you found any particular barriers to getting more involved in research?
Yes, Jen Shaw's in our research department, so we do have research. We have to go through the IRB to get approval on research of any of our customer owners, and that is a pretty big deal. I've heard quite a few times they have declined. No, we're not interested. This would not be good, because of what has happened in the past with research on Alaska Native people. And Jen and her team does a great job of trying to incorporate what we have going on the ground and get it to the academia area and to programs like SAMHSA and IHS that can help fund the need of the people for this topic. Yeah.
Okay, that's very helpful. One other related topic, I heard the theme throughout the day today, but here as well, around payment. And it sounds like the breadth of involvement that's required from providers, care team members, family included, is far beyond a simple reimbursement code. Have any of you seen models where you feel like the payment mechanism is aligned with the care that needs to be delivered? Silence for those of you listening.
Well, I can't speak to that, but what I will say is one of the things that at the VA, because we are designated to provide suicide prevention care, that is our whole role. And I do think that there is some comfort with our veterans who know that that's what we're here for. That I'm not going to say, oh, well, your hour's up, you gotta go, I got someone waiting. They really know that we are here for them in that crisis. And I think that from their perspective really helps them to trust the process and actually be open about their risk for suicide, because they don't feel as though we're going to rush them off. And I think that comes up when you're talking, tight schedules and providers where we're enhanced care, and so we actually add above and beyond what the usual care is. And I think that works, where we're not rushing the patients, we can provide enhanced care, and then the providers still have their roles, and it makes the veteran feel like everyone's working as a team to support them.
It's helpful, definitely.
I think the VA, I've been jealous of the VA system, and many of the innovations in the area have actually come out of VA systems. And I think part of it is because they've been under a more flexible payment system. There are places, we have in Georgia, we have moved more toward a fee for service, which is lethal. Partially because many of the approaches that we need to do, if someone's suicidal, one of the main things is, do we want to be in contact with them? Yes. If I want somebody to be in contact with this person today. if I'm calling them, I can't get paid for that. If I'm having a case manager do something with them, they're not getting paid for that. Those kinds of things. There are systems where there are other approaches where you get paid, and many times some of our more innovative approaches historically have been in systems where they have used a different payment system, sometimes to take care of a population, sometimes not to prescribe a traditional approach. Sometimes we find the more effective approaches may not be so institutionalized or so mechanized or so patient-oriented. That we're actually where there's flexibility, where people can function more as a team. I really do think the empowerment, some of the work that people talked about, some with the peer involvement, some of the work that where people can collectively include other members of the society and the family and so on like that, and where that's not paying is detrimental. And there are systems that do a much better job at that in different parts of the country. And I think we see some of that reflected, some in suicide rates, but also more in terms of people's adapting to the community in their life.
That's helpful. The key takeaway, I'll paraphrase there. I think I heard fee for service is lethal, which I often think but don't verbalize. So I'll go ahead and put an exclamation point. I love that. Frida, maybe if I could ask you're as frontline as it gets. You get to see addictions, you get to see mental health, you get to see housing. Does the payment ever factor? And you can be honest. So I'm Frida's boss's boss's boss, right? You're here because you're one of our best staff, so you can't say anything wrong. Does payment, but when you're providing care, when you're overseeing housing, does the money side ever factor into your decision making, or do you ever feel like, oh man, I don't know, we're not going to hit our numbers, or can you elaborate on if you ever feel, and be honest?
Well, I usually hit my numbers.
Right, true.
But I have to think about the client, and you know Andre, Dr. O rather. So our groups are our groups. We have clients that go to our groups that are in housing and sometimes won't pay. It's okay. Maybe the next month I'll see how I can work with them financially. And we have groups all day that clients go to the same group. So it's really not focused on the money, even though the money is important, even though the pay, because we have to get paid. And but it's all about the client. It's about the client. Clients come on in. This is what you need. If you need to go to this group, okay. You're only getting paid for one group. Go to the next group. Go to the next group. Go to the next group. So we definitely don't do that at Concerted Care Group. Now I have worked for agencies and facilities because I've been doing this for 20-some years, where nope, only get paid for one group. You can't go to the next group. And to me, that's not doing the client a service. Suppose Nikole needs to go to this group. So she needs that next group also. So, no, I don't. That's honest.
That's helpful. And I want to elaborate on something you mentioned, which is true. You are one of the most productive employees we have. And that's a reality, right? So the number, Frida knows her numbers, and the fact that we even have to have numbers to gauge productivity is an important nuance here. So it's not like the financing is completely in the background. It's not like we have a capitated premium where for each member we get a certain dollar amount per month and we just do our best, whatever we could. The more counseling we do, the more money we make, and that's important. And I'll contrast that with in Maryland, at least at one N of one, the middle of 2017, before that time, the payment mechanism in Maryland was structured differently. In particular, it was even more fee-for-service oriented, and our organization actually had about 15% of our revenue come from lab testing, and the lab testing ended up getting bundled or rebundled, where we still can do lab testing, but we don't get paid any more or less based on lab testing. And so now we have 0% of our revenue coming from lab testing. And what became unbundled was counseling. So counseling effectively became fee-for-service with certain constraints. And while I think it isn't the holy grail of here's a lump sum, it's a reasonable dollar amount, do your best to do the right thing for the consumer, I think there are some interesting payment mechanisms that aren't completely fee-for-service that I think are worth exploring. Importantly, I think they need to be tested. And this gets to my prior question of, are we evaluating appropriately in diverse enough populations? And I think given that SAMHSA has graciously sponsored this, food for thought for SAMHSA, where your investment dollars go, and where your research evaluation dollars go potentially, and also other federal and foundation partners as well. So we, I think, are going to conclude here. We're going to conclude just a couple of minutes. Oh, you have a question? All right, we can do one more question. Sorry. Let's do it.
I just wanted to ask, this is Bridget Kelly from the National Academies. I just wanted to ask if maybe as a final round among the four of you, is there something that you, like once a day or once a week, say to yourself, if only this were different, I could do a much better job for my patients or clients or customer owners? I'm looking for that thing that's really just constant for you. And it might be something you've already mentioned, but something that's really getting in your way as providers all the time. That's maybe something, if we zoomed out and took kind of a policy or a research lens, we might be able to help address.
Yeah, for me, I've already mentioned it. It's two things. It's the psychiatric unit in the emergency room for the safety and the privacy, because we go in and when we do our assessment, other people can hear. And that's not conducive. That's not fair to that patient, that other people could potentially be hearing their history and their story. And the other one is the intensive case management to help keep an eye on people who are out there in the community who may not have a right to make their appointments to get their medication or to make sure they're taking their medication and not taking it, and then they have a psychiatric crisis or emergency because of the lack of medication.
I was going to say, for me, one of the things is stigma. I feel like that, and I've been through it personally, so I know. I had an aunt who came up to the front of the funeral and said, "I'm so angry at you." Not understanding that this is not, it's not selfish. It's someone who is in immense pain and has no other option, feels as though they have no other option. And for me, if we can really just start talking about suicide and not be afraid to talk about it. We do information tables and at veteran events, and people go by all the information tables, they see suicide and they just walk on by. And so my thing is really, if we could just start talking about it like we do diabetes, maybe our veterans or all individuals, because this is a national crisis, not just our veterans, but the VA is leading the way. But if we could start talking about it openly and not having guilt or shame associated with mental health and suicide, I think that people will really open up more. One of the things I hear from my veterans all the time is that whenever they mention suicide, there's just an automatic response. We got to escort you to the emergency room. And stratifying that risk and being able to say, I understand that you're having the thoughts. It's okay as long as they're not having the behavioral ideas. We can really address that, and it would be okay for them to be comfortable with that, that these thoughts do come and go, but I'm able to control them, I'm able to manage them. But there's so much guilt and shame, it clouds that process. And so that's what I'd like to change.
And I say this all the time, and I got it actually, excuse me, from Andre. He always talks about transparency. So my coworkers, they always tease me. It was like, you got that from Andre. I was like, but I'm serious. And I like the whole transparency part. And that's what I always yearn for from my clients. I want to be transparent to them also. and I want them to be transparent. But in order for them to be transparent, then they have to trust me. So I always, every day, I say, okay, let me see how I can be transparent to them so they can trust me. And that way, if they trust me, I'm able to help them and they're able to receive my help. So I do that every day.
And mine would be shifting from pathology, an emphasis on pathology, to an emphasis on adaptive functioning.
Great. Thank you.